Okay, I think we have to start the session. I'm Dr. Hsien-Li Kao from Taiwan. Actually, I'm in position for Dr. Wu Jiongren, who couldn't make it because of the snow. So together, we have Dr. Kefei from Beijing to co-moderate the session with me. We also have distinguished panels. But anyway, we will start the session with the first case by Dr. Han. I'm sorry, please.
Good afternoon. I'm Dr. Jung-Kyu Han from Hsien-Li Hospital. Today, I'm going to present a case of Stumpless LED CTO. This patient was a 59-year-old gentleman, and he was diagnosed with esophageal cancer in January last year, and he was on the palliative chemotherapy since February. And he visited the emergency room for exertional chest pain, lasting 2 days in June last year. And the EKG shows ST elevation in the inferior leads, and cardiac markers were elevated. You can see the elevation in ST segment at the inferior leads, so he was diagnosed with STEMI. And choreangiogram was performed. There's a Stumpless LED CTO, and there's a diagonal branch supplying diesel LED through the epicardial collaterals. And here's a Stumpless LED CTO just after diagonal branch, and you can see the calcifications at the CTO body. And this is area caudal view. There's no clear-cut LED proximal cap. And the right corner angiogram showed the thrombotic total occlusion at mid-RCA. So PCI was performed through proximal to mid-RCA using 2 stents. And the RCA angiogram showed the CC1 thread-like collateral from PDA through the septal branch to LAD. And the echocardiogram just a few days after this index PCI showed normal ejection fraction. There's no significant wall motion abnormalities. So in sum, this 59-year-old gentleman was on the palliative chemotherapy for esophageal cancer. And emergency PCR is done for RCA STEMI, and LAD, not osteo, proximal LAD, Stumpless LAD CTO was found. Here's the case.
Okay, thank you, Dr. Han. So we have a Stumpless MLAD CTO, and I will ask Dr. Tsuda to present his strategy if he was the operator.
I'm very honored to be here to be invited to Complex PCI 2024. So anyway, let's move on. How would I treat this case? This is my COI. So first of all, before the CTO PCI, we have to discuss about the indication of the CTO PCI. So this case is a young age and middle age CTO and the normal AV function. So that echocardiography also show that clearly identify that the hereditary is viable. However, the ischemic area should be identified scintigraphy, or we have to consider about the prognosis of the esophageal cancer also. So after the indication, the CTO assessment should be the next step. So that the CTO morphology, so that no stump, no entry of the CTO just after the diagonal branch bifurcation. So the CTO length and the exit and the CTO plaque component is also not clear because of the D1 first diagonal apical channel is not clearly show that the CTO distal exit. So that the cardiac CT could be identified clearly the CTO length or the exit or the plaque component inside the CTO. So after this kind of assessment, we will focus on the difficulty of this CTO case. So first of all, the CTO is not clear by using the ipsilateral collateral flow from the diagonal branch. So improving to clearize the CTO exit, the guiding caster, larger guiding caster is one option to clearize the CTO distal. But during the antegrade approach, the antegrade injection is a high risk of the creating the subintimal space or the hematoma. However, the no distal target is very difficult to perform the antegrade guide wire because the guide wire could not know that where to go. So that to create the CTO exit, the microcaster injection is one option from the diagonal apical channel. So, however, this kind of the procedure could not clearly identify the CTO exit. Maybe the retrograde approach is one option for the clearize the CTO exit, because if the retrograde approach could be established, the guide wire and the microcaster is clearly identify the CTO exit. So another point is this diagonal branch is very difficult to perform the retrograde approach. It's possible, but very risky for the perforation or the ischemia during the procedure. So in this kind of situation, the balloon occlusion technique is one option. This is my case of the RCA CTO. So the other collateral flow, the AC channel is dominant collateral flow from the LCA. So at baseline, show that the AC channel and the septal is dominant, but balloon occlusion was performed from the at the AC channel site. So circumflex apical channel become very clear, so that it could be possible by using the retrograde approach in this case. So anyway, this case, my strategy is around this kind of this one. So first of all, the bilateral injection by using the guiding caster to check the CTO exit visuality. So second, the collateral check by the first diagonal balloon occlusion technique to check the retrograde interventional collateral channel. So after that, the antegrade approach was initiated by using the real-time IVUS guidance from the diagonal branch, and puncture was assisted by using the DLC. So after that, the antegrade approach was failed. It depends on the collateral flow or the retrograde channel flow. So the parallel wire was initiated if the CTO exit was well visualized, or the retrograde approach was initiated if the intervention collateral exists. However, if neither CTO exit visualized nor interventional collateral is known, the IVUS guided wiring by using the tip detection or the tip detection ADR was performed. Thank you.
Okay, thank you for your detailed analysis on the case. So let's hear from Dr. Han, actually what he did.
So thank you for the valuable comments, and here's how I treated the case. So considering this patient's chemotherapy schedule, about 2.5 months later, I performed a planned intervention to the medial LAD CTO. And this is the baseline angiogram at the time. Here's Stumpless LAD CTO. There's collateral from diagonal branch through the epicardial collateral, this route. And bilateral angiogram showed the faint thread-like collateral from the PDA through the septal collateral. And proximal cap should be located around somewhere around here. And the CTO segment length is longer than 20 millimeters from here to here. So there's two collateral from PDA and diagonal branch. So this patient is blunt end, and there's a calcification, and region length is longer than 20 millimeters, and JCTO score was as calculated as 3. So as a first step, I tried to cross the proximal cap under the guidance of IVUS. I used finally Sasuke, Doubleman caster, and used the miracle wire. You can see the proximal cap here, but it was very slippery. So finally, I couldn't cross the proximal cap unregularly, even under the guidance of IVUS. I used the EBU 3.5 8-French guiding caster. And this kind of thing frequently happens when you are doing Stumpless CTO interventions. So I changed my strategy to the retrograde approach. Here are two options. First one is a septal collateral, CC1 from PCI branch. And another one is very relatively big, well-developed collateral, but it's of course very tortuous because it's epicardial collateral. So I think anything of these two options could be adopted. And actually, I studied this epicardial collateral. And before that, during the IVUS assessment, I found that this patient suffered angina and SD change. So there's a significant stenosis through the small diagonal branch. So I performed the balloon angioplasty and before tracking the epicardial collateral. And this is angiogram after balloon angioplasty. And of course, I didn't want to place the stent in this small diagonal branch. And then I tried to track the epicardial collateral starting with the Sion wire because it gives us more supportability compared with the Soldier 3. But at this point, it's very tortuous. There's several multiple 360-degree turns. So at this point, I need to change the wire for the Soldier 3. I carefully advance the wire and then perform the tip injection. Here's a very tortuous collateral through the epicardial pathway. And then I carefully advance the wire again and advance the microcaster. And again, careful tip injection showed there's almost there, target is almost there. And this is the final wiring using the Soldier 3 to the LAD distal part. And now microcaster was placed at the advanced to the distal cap of the CTO segment. And this is angiogram after this epicardial tracking. And I tried wiring using Miracle 6, and finally it was escalated to the Gaia next third. And the spider view, wire passed through the proximal cap, and finally entered the guiding caster. But one pitfall during this strategy was that I couldn't perform the live IVUS imaging because diagonal branch is not big enough to accommodate both microcaster and IVUS caster. So I could do without any IVUS live imaging. And then microcaster was advanced through the proximal cap and finally to the guiding caster, and wire was exchanged with, for the RG3. And then I performed the low pressure balloon angioplasty using 2.5 volume. And this is angiogram after balloon angioplasty. And there's no good flow. And what it means is wiring was actually passed through the subintimal spaces through the CTO body. So I advanced the antegrade microcaster, and then I performed the tip injection to check there's any perforation of epicardial root, and there's no that kind of complication. So I performed the IVUS at this point, and as you can see here, distal part, at the distal part of LAD, wire, of course, is located in the true lumen, and then there's severe calcification through the CTO body. And then at this point, wire passed through the subintimal space, and true lumen is displaced by this false lumen. It's calcified true lumen, and wire is placed in subintimal space. There's severe calcification, and then the diagonal is here. Why is still in the subintimal space? This is LAD, true lumen. And then finally, at the proximal cap, proximal LAD, wire passed through the true lumen at this point. And then here's diagonal branch, and it's left main. So if I place the stent through this route, then I will lose this huge significant diagonal branch. So what would be the next step? Next should be LED wiring under the guidance of Ives. And because I performed some low pressure balloon angioplasty, I could get plug modification. So at this time, when I use supercross 90-degree, the wiring through the proximal cap was much easier compared with the initial trial to pass through the proximal cap. So finally, I used the Gaia next third wire, and it could pass through the true Roman and LED, and this is previous wire, passed through false Roman, and this is true Roman, and Ives shows that the wire passed the very calcified CTO segment and then placed in the true Roman at the proximal LED, medial LED actually, and then proximal LED, and this is the previous wire placed in the subintimal space. So balloon angioplasty was performed at this time 14 ATM. This is angiogram after the ballooning, and you can see the good flow through the distal, middle to distal LED. And I placed the two stands from LED ostium to medial LED, and this is the final angiogram. So I could save the LED through the true Roman. So during the follow-up, this is the result of follow-up. And just before we did the CTO intervention, chemotherapy showed partial remission. And after the CTO intervention, he took the radiotherapy. And now, fortunately, he was in the complete remission. There's no evidence of a tumor at this time. And until for 1 year, he has been in very stable status. So here's take-home messages. What is best timing for complete revascularization after STEMI? We have many studies showing superiority of CR in STEMI patient, but the best timing is varies depending on the studies. And in one study, CR was performed simultaneously with IRA, infiltrated artery revascularization, and another study, time was determined at the physician's discretion, but enriched during the index in hospitalization. And in another study, PCI performs stagedly, but within 45 days. And the results showed that both index hospitalization CR and after discharge CR showed better outcome compared with the non-CR. So at this time, currently we don't have any clear-cut answer regarding the best timing of CR in these STEM patients. And CTO intervention is indicated without any further workup like SPECT. I would say yes for the patient to the proximal to medial AD, because the patient with the proximal to medial AD CTO, there should be huge amount of ECV burden, and the echo shows that there's definitely viable myocardium. So I would say yes for the indication of CTO intervention. And CTO intervention is required in the cancer patient. And actually, in this specific patient, I'm happy with the result because the patient is now in the CR after CTO intervention and radiotherapy. And I did my own best to save his life. And so I'm happy, very happy with the result of this patient. And Stumpless, during the Stumpless CTO intervention, retrograde approach is often required because proximal cap is very slippery. And during this procedure, Ives assessment is, of course, is essential to confirm the root of wire. Thank you for your attention.
Okay, thank you for your wonderful case. I think very educational. I think the most important step is you use Iris to find the true lumen. So it's very important for every operator. And any thoughts from our panelists? A comment?
Okay, thanks for the nice case sharing, Dr. Han. So previously, Dr. Tsuda mentioned, so definitely pre-CTO, CT scan, would be very helpful. And also, if you did some successful retrograde direct crossing, anyway, the high risk of the side branch jailing because of the entering of the first lumen. So definitely we need the antegrade preparation is essential. Even with the first lumen or true lumen, anyway, antegrade wiring, increasing the wire weight up to the 12 gram. And also the second comment is if you did a successful an ipsilateral retrograde system, so if that you already did a bilateral approach, so the additional different guiding catheter system would be better or would be easier to perform the retrograde PCI.
Yeah, thank you for your comments. And regarding your third comments, you mean the ping-pong guiding one, guiding caster, right? But in this case, I used the 8 French guiding caster. So if I used the 7 French guiding caster, ping-pong would be required, but 8 French would be enough, I think. And regarding your second question, yes, if I try the harder wire tip, I would perform the successful integrated approach. I'm not sure if we have a stiffer wire like Conquest Pro 20 or Conquest Pro 12 ST sharpened tip like in Japan, it would be successful or easier, but unfortunately we don't have any wire like that. We only have Conquest Pro 12, and actually in this kind of Stumpless CTO, proximal cap is usually very slippery and sometimes it's not, frequently it's not very successful, so that's why I tried retrograde wiring.
Because you could not enter the stump, so you could not do the integrated preparation.
Yes,
why
that's right.
You directly did the retrograde.
Thank you.
First of all, I'm very happy to hear that Dr. Tsuda expressed the 90-year-old man, young patient, same age with me. So it's good. And first of all, your first strategy, when I look at the bilateral injection, I could see after RC PCI, there's a few, even slender but straight course, few more good safer channel instead of epicardial. Epicardial, this can be feasible in my experience also, but more priority will be in terms of safety issue. So retrograde, but before the retrograde bidirectional approach, when I look at the initial index PCI, the more prolonged the injection and waiting for the bidirectional, the end-to-end, it looks very short segment. So, and fluoroscopic calcification, especially in the spider view and other view, we can assume the accurate best course. So you already identified the IVUS in the entry point. So UB3 is not proper wire selection for this point attack. Point attack is very important in this situation.
Yes.
And so I would do maybe at least Gaia second or the Conquest. Why not? It can be feasible like a Conquest Pro 12.
Yes,
so my comment is just integrate the preparation and entry point making trial is limited from the beginning. So that is point. The second important thing is before the ballooning, it's better to retract the true lumen, because otherwise it's good because you succeed, but if you fail, then you will sacrifice the important diagonal branch. So accurate isolation of CTO body is very important, bidirectional approach. So identification of an exact retrograde entry point. If you are not confident, it's better to do IVUS guided and another point attack to enter the distal junction. That is my opinion.
Yes, thank you for your comment. And regarding your first comments, I actually started with UB3 to feel how hard the proximal cap is, but actually, and then I quickly escalated the wire to my Miracle 6, but Miracle 6 was still slippery. So if I use Conquest Pro 12, it would be successful or not, I'm not sure, but because we frequently see very slippery proximal cap and Stumpless CTO. And regarding your second question, I performed the tip injection. Actually, I didn't include that angiogram in here, but the proximal, the distal microcaster was pressed at the point of distal cap, so CTO segment is not that long, not that short actually. It's longer than 20 millimeters and over 30 millimeters, I guess. And actually, this patient took a CT angiogram before, almost 1 year or 9 months before the index procedure for healthcare checkup. And the CT angiogram shows very calcified segment through the LAD. So, and then I performed, this patient visited the ER, and I performed the angiogram, and then I performed the IVUS. So I thought I couldn't get any further information if I repeat the CT angiogram to get more radiation for this patient with esophageal cancer. So that's why I didn't repeat the CT angiogram. And CT angiogram clearly showed very calcified CTO body, as you saw in the IVUS assessment.
Okay. It's time to move to the next case. I think the presenter will be Dr. Yuji Hamazaki.
Yeah.
Please.
Thank you, Chairman. I'd like to start my case. My case is a live case in Adata live demonstration this year. And Adata live demonstration is one of the famous live demonstration course in Japan. And the patient is a male in his 50s. He received CAZ because of abnormal CAZ and reduced cardiac function. And the CAZ showed us triple vessel disease, including a CTO. And before CTO PCI, LAD and LCX already treated. And in both PCI, IVL was used. It means coronary has severe calcification. And the syntax score is 29, and renal function is not so bad. This is a diagnostic CAZ. As you can see, CTO start just beyond big RV branch. And island exists in CTO mid part. CTO start here, and we can see the island. And this is LCAZ. As you can see, a good collateral gives, LAD gives a good collateral to RCA, and maybe retrograde approach is not so difficult. And the CTO exit is a bifurcated exit, like this, no stump exit. CT showed a severe calcification at the proximal part, including a CTO. Calcification is located at the deep side. However, partially full moon calcification. Honestly, I didn't think it is not so serious, but it's very, very serious. This is a baseline CAZ of my procedure. And my system is one femoral approach and one radial approach. As a guiding catheter, JR4 used for RCA. First, I used 8 French AL1, but AL1 could not be engaged, so I have to use 7 French JR4. And VL 3.5 used for LCA. Gaia next one.
Would you please stop here? I think Dr. Paul will.
No. Not yet. Not yet.
Okay.
Please continue.
Okay.
Thank you. And the Gaia next one could be advanced into CTO like this. However, any device, Corsair, Fine Cross ZT, Balloon, Tornus 88, could not enter beyond just proximal site of CTO, around here. Of course, I use anchor balloon technique, but cannot. Antegrade approach stacked, so retrograde approach was started. Retrograde wire with UV3 and Gradius EX could be advanced, and retrograde wire crossing with Gaia Next 2 could be achieved. I use other guide wire from a retrograde side, not only a UV3 and Gradius, but also Xeon Black and XTR. But as you can see, this part has a bending. So only Gaia Next could be past this part. Retrograde guide wire could be advanced into guiding catheter for RCA. In general, it means procedure almost finished. However, I still have a long way to go. However, any microcatheters, GZI, fine cross DT, mogul, could not pass CTO from retrograde side. Of course, I use a trapping technique in the anterograde guiding catheter. This is a discussion point. My situation is CTO with severe calcification at RCA. Antegrade guide wire could be advanced into CTO, but any device could not be advanced at the calcified site. Retrograde wire crossing could be achieved, but any microcatheters also could not be advanced from retrograde side. What is the next step?
Okay, thank you. And next, Dr. Kao will tell us what is his plan.
So, Yuji, you are in a very difficult position. But I was even in a more difficult position. You know why? Because I'm not supposed to be here. There should be another Japanese doctor to answer your question. But I was told by the staff at noon today that I have to replace. And I don't have a chance to actually look into detail your cases or prepare my slide, of course. And the staff say, okay, you can just talk. Out of respect, I think I just talk is not appropriate. So I just prepared 2 slides. I think this is really a tough position where you have your antegrade wire crossed, but none of your device can follow. And your retrograde wire crossed, none of your device follow. I think that's your position right now, right? So just in a very logical fashion, I came up with these 2 simple slides. Now you have an antegrade wire in position, but nothing cross. Of course, then you should think about enhancing your support. You can do anchoring, which you have done. You can change your guiding catheter. Of course, with your wire, you have to do a extension wire exchange, but that is something can be done. Or you can use guide extension to further improve your enhanced support. And after that, you can always change your microcatheter. Of course, you have changed a lot, but sometimes by changing to a new microcatheter will give you miracle, because sometimes the used microcatheter is already fatigued and cannot make the pass, and changing to a new one will help. And then after that, you can also attempt the granuloplasty, which means that you jam a small balloon as far as you can, and then inflate the balloon so that it ruptures. That's called a granuloplasty. If that failed or cannot be done, you can use a dual lumen catheter and then put your another wire intentionally into the subintimal space, just proximal to your uncrossable point, so that you can advance a balloon to do some external plaque fracturing. Once you have squeezed the plaque subintimally, sometimes the intraplaque device can be passed. Or if you have this device available, you can do laser. If not, then finally you can do an in situ swap into a rotafloppy wire, so that you can do rotablation on the calcified spot. That is my logic or steps if I have an antegrade wire in position. But now you also have a retrograde wire in position. Again, what can be done? Again, we can enhance the support by anchoring, by changing of a guide or a guide extension. Same thing with the antegrade. And also you can change your microcatheter, like what I have said. And also one tip here is that sometimes when we think about changing the microcatheter, we go for the same 150. But sometimes you go for a 130, the shorter one, because the shorter one will actually give you a better antegrade push. So not just a microcatheter, but also changing the length of the microcatheter if you can. And also, you can do retrograde dual lumen catheter and then puncture a wire intentionally distal to the distal cap so that you are subintimal. And then this time, you can use a wire to push the knuckle to follow. And this is similar to the antegrade external crash. And this time it's fractured by a knuckle of the wire. And you can also do a chase wire technique after tip-in, which means that your retrograde wire now is in your antegrade guiding catheter. So you can advance a antegrade microcatheter without a wire so that you can achieve tip-in. And once the antegrade microcatheter is on the wire, you follow with a wire so that two wires are touching each other. This is called a chase wire, so that your antegrade microcatheter will have more push, and maybe this could be successful. Or finally, you can also, from the retrograde direction, in situ swap into a rotablation wire. Of course, this wire will exit with a floppy head, but you can cut off the floppy part of it and then advance your rotablation from the other end so that you can do the reverse rotablation. So basically, these are my advices or choices, but let's see what Yuji can do the miracle on this case. Thank you.
Okay. Thank you, Paul. Gave us a lot of very important technique, and we will see what will Dr. Hamazaki, what did you do?
Yes, I want to hear Dr. Kao's opinion before procedure. Okay. And first, I use a cracking plug technique. I love it. So, in general, I perform a fast technique in such situation. And the parallel wire technique with Miracle 12 and the Conquest Pro ST from undergraduate side to make crack and space was used. And in some cases, it's very effective. But however, in this case, it could not work well like this. After that, during an attempt to insert microcatheter after cracking plug technique, of course, I try again and again and again. And finally, antegrade system came out into aorta. As you can see, guiding position is very good, so backup support, it means that backup support is very good due to anchor balloon technique. So, rewiring with my Miracle 12 was performed from antegrade side. And then, antegrade guide wire route changed. It's thanks to maybe a cracking plug technique. And the Miracle 12 could advance toward a retrograde microcatheter like this. It looks like Miracle 12 touched tip of retrograde microcatheter. In RAO view, guide wire position also looked good position like this. So I thought it's time to perform a rendezvous technique. So antegrade microcatheter was advanced as deep as possible. And the antegrade guide wire was removed and exchanged to rotor wire drive floppy. And the rotor wire could be advanced. You can see. And advanced into a retrograde microcatheter like this. Rotor wire could pass CTO easily because rotor wire was only advanced through retrograde microcatheter. Of course, I perform a rotablator, and the rotablator with 1.25 bar and 1.75 millibar was performed. After rotablator, stenting was performed. This is the final CAG. Final CAG shows good results. Big RV branch also opened.
Yeah.
Yeah, of course, in such a situation, we have some solutions. And exchange microcapacitor, of course, first I use a microcapacitor balloon and a torus. And the next step, cracking plug technique with CTO wire. After that, rendezvous technique with rotor wire drive. Of course, the other option, direct undergrade crossing with rotor wire drive is one option. But in this case, region length is too long to perform this technique. So I think it is not so easy to perform in this case. The other option, of course, I didn't do in this situation, and the direct retrograde crossing with RZ3. And this case is I performed a CCT 2019 and RCA CTO, and the CT showed a very calcified region. And this case also a retrograde wire crossing could be achieved. However, any device could not advance. In this case, I also used the cracking plug technique. However, could not work well. And then direct crossing with RZ3 from retrograde side was attempted, and RZ3 could be pass CTO. After that, small balloon could pass CTO from undergrad side like this. The reason is the small OD outer diameter of RZ3 changed friction between guide wire and region. And the next option is intentional subintimal wiring. And in this case, guide wire, both sides overlapped. But reverse cut could not be performed because any device could not be advanced into CTO from undergrad side. So, in this case, I use intentional subintimal wiring like this. Undergrad wire was advanced through the subintimal space intentionally, like this. After that, balloon could be advanced into CTO easily, and reverse cut could be performed. And reverse cut, after reverse cut, CTO crossing could be achieved. So, and I didn't have experience of use of laser in such a situation, but it may become one choice in such a situation. So, it's my conclusion. The problem of this case is any device could not pass CTO after retrograde wire crossing with retrograde approach because of calcification. Exchange of device and the cracking plug technique by CTO wire could not work at all in this case. And the reverse cut outside of calcification was not used in this case because of location of calcification around CTO is a deep position. So it is not so easy to advance guide wire to a subintimal space in this case. And I want to protect RV branch, big RV branch. And finally, integrated rewiring and rendezvous technique with rotor wire drive is useful for solving this situation. Thank you for your attention.
Thank you for your wonderful case. Your case tells us that CTO is not the most difficult. Calcified CTO is. Yeah. And I want to listen to some comment from our panel.
Thank you for nice presentation, Dr. Hamazaki. You make the backup support is by the anchor balloon and the strong guiding catheter. I think if you use the extension catheter such as the guide Jula, it makes a simple advanced micro catheter into the calcified region. So why you don't use the extension catheter in this case?
Yeah, I think backup support is enough. In use of anchor balloon technique in this case. So, of course, as you said, your opinion is one option. Yes.
Thank you for your nice case, and I want to ask a very simple question. You did the success using the retrograde microcatheter and Langdue technique, but if your retrograde wire cannot reach to the occlusion site and the Langdue technique could not be achieved, if only the rota wire can pass through the calcification and do not enter the true lumen, do you do the rota technique also, even though you did not enter the true lumen in the distal part?
Yeah, of course, I don't have a special technique to advance the rotor wire in such a situation. But as you can see, the Miracle 12 is advanced a very good route. So I think Miracle 12 already make a route. So, and as you know, now we can use rotor wire drive. Rotor drive is a very high quality compared to old one. Yeah. So I think I saw the Miracle 12 position. Rotor wire can be advanced this route, I believe.
Yeah.
Okay.
Yeah, I think rotor drive wire is a very good, very workable wire, not like the old one. Yeah, but even though if you cannot achieve distal true lumen, you can still do partial rotor.
Partial rotor
maybe
is
just,
one option.
Yeah.
Yes, I know. Yeah.
So if your rotor wire can't cross, maybe you can use a RG3 from retrograde go to the antegrade guiding, and then...
Yeah, I already said in the presentation, distal part of calcification has a bending, and from the retrograde side, only Gaia next to 2 could pass, and XTR and the Sion Black could not pass that point. So, of course, if such guide wire could pass this route, I want to attempt retrograde RG3. But in this case, it is not so easy to pass the RG3 from a retrograde side, I think.
Thank you for nice presentation. In my idea, I would have done the same course, intraluminal, the rotor ablation first. And in my expansion, second option is because even successful wiring, we should deliver the next device. So calcium neglect strategy, like your expression of intentional subintimal, that is good idea. And my additional comment is because the retrograde interventional channel looks good space. So we can, because distal cap is usually softer, and the distal tracking, balloon trapping, and the pushability is increased, we can deliver the retrograde small ballooning and making more space. And sometimes I'm doing the bidirectional ballooning. Bidirectional. Smaller, and sometimes we can make it.
Yes.
And second option is, we have more options like intentional balloon rupture and making, variety of the tonus device like your, and any other debugging. So this is a very good educational case. Thank you.
Thank you. That was a wonderful case. Thank you. So let me invite our lecture speaker, Dr. Kim. He will be talking on current perspectives of imaging-guided CTO PCI. Okay, looking forward to your talk.
Thank you, Chairman. I would like to summarize and share the current perspective of image-guided CTO PCI. This is my disclosure. So the imaging tool can be valuable for the following steps. The first one is for the successful wiring, and then for the successful clinical outcome after successful wiring. So for the successful wiring is for Stumpless CTO, the IOS guidance is a very typical use for the successful wirings. The useful in rebuilding the entry point of the occlusion, and also useful in repositioning of guide wire in the event of the subintimal passage. Definitely pre-stenting IOS evaluations could cause the accurate information regarding vessel size and lesion length and characteristics of plaque, and also sometimes we can easily detect the complication of CTO PCI and also determine the exact location of guide wire, true or false. So recently, a new usage is being introduced. As Dr. Okamura reported, the tip detection method using the new IBUS system is tip detection method enabled to perform the IBUS-based 3D wiring, which will be further facilitated by the use of the new IBUS system is anti-owl IBUS system. So the movement of the transducer back and forth and also the 15 centimeters pullback length is enabled this technique. So more recently, the tip detection ADR method was published with Dr. Okamura. It's combining is a tip detection ADR with a Conquest Pro 12 is a new ADR wire with the strongest penetration force developed to date, enabled to entry anywhere except the calcification site. And also the pre-procedure CT scan before CTO PCI is sometimes very helpful for the successful wiring, 3D volume rendering, and MPL image corresponding to the two orthogonal invasive angiographies, and also the assessment of longitudinal and cross-sectional image. From this analysis, we can evaluate the CTO path, tortuosity, and also the assessment of anatomical location associated with the side branch, and we can evaluate the CTO length, characteristics of CTO plaques. This kind of quite similar with the role of IBUS, and also we can easily evaluate the amount and distribution of calcification like this. So based on these pre-procedure CT scans, we compare the role of the CT scan for the successful recanalization of CTOs. When you compare the rate of the successful recanalization between the CT-guided versus angio-guided, is a CT-guided CTO showed significantly improved the successful CTO wire recanalization, especially the difficult CTO. So what about the clinical outcome, the usage of the image-guided CTO PCI after successful CTO wiring? So from the CTO IBUS study, this study was the first randomized trial investigating the clinical benefit of IBUS guidance for CTO intervention after successful wiring crossing. So this study demonstrated, as compared to the conventional angio-guided CTO intervention, IBUS-guided Shin-to intervention, it caused a more frequent use of a high-pressure post-dilation and larger post-procedure MLD. Finally, significantly improved the clinical outcomes after DS implantation. So on the per protocol analysis, cardiac deaths or MI, such as fatal events, is also definitely significant difference between two different strategies, even with the definitely TVR reduced by the IBUS guidance. So usually, how to improve the clinical outcome in complex regions? So based on the data is in imaging guided group, usually the post stent pressure is very high, and also the frequency is also greater as compared to the angio guided group. These two is definitely related with the improved clinical outcomes. Definitely that is the stent optimization or not. So IBUS guidance obtaining the stent optimization would be the key for the better clinical outcomes. IBUS enabled to evaluate precise reason evaluation and adequate stent expansion or not, and also detect the complication. So a simple applying of the imaging devices does not guarantee the successful result. So what about the outcome of stent optimization and also IBUS criteria for CTOs? From our image registries, we compare the clinical outcome of the stent optimization versus non-stent optimization, especially the CTO lesion is most determining and as precise criteria was MSA greater than 4.2 or 75 relative expansion. So based on these criteria, definitely different clinical outcome, some importance of the stent optimization, especially CTO reason. So, and also when you look at some serial IVUS or angiographic data, so as everybody can know, is sometimes after CTOs, the distal vessel is shrinked. When you look at and investigate the instance of the distal vessel expansions, it's 2/3 patient was showed some distal vessel expanded. So this kind of distal vessel expansions is definitely related with obtaining of optimization or not. So this is the recent RCT regarding the imaging guidance versus NGO guidance for complex reason, Renovate trial, Illumine 4 trial, October trial, and our Occupy trials. When you look at some inclusion criteria, is Renovate, Illumine 4, and Occupy include the CTO lesion. So the Renovate complex trial was the target vessel failures definitely low in the image guided group as compared to the NGO guided group, even though in this trial is most cases done by the IVUS guidance is less than 30% is OCT guidance. And this when you look at the subgroup analysis, the reason with the CTO or not, definitely CTO is also imaging guidance show the low rate of the target vessel failure. And this is the subgroup of the Renovate complex is intravascular imaging guided PCI associated with reduced target vessel failure in a CTO patient, graded the risk of the target vessel failure according to the stent optimization by imaging support the importance of the image guided PCI and achievement of the stent optimization in CTO intervention. So this is also the subgroup of the Illumine 4 trial. This is the complex region subset. So as you can see in the CTO region, this is the OCT guided versus NGO guided group. Even though the not so many cases, however, anyways, there was no group interactions. Definitely, the better OCT guidance was maintained in this sub-study. So our center is also a recent ESC, the reported Occupy trial is OCT guided versus NGO guided in complex reasons. When you look at the occurrence of a primary endpoint MACE, definitely OCT guided group showed a significant low rate of the MACE rate, especially the reducing the spontaneous MI and target vessel related MI and TVR. In these studies, we suggested Occupy OCT optimization is importance of the stent expansion, opposition, and edge dissections based on the patient with sub-optimization versus stent optimization. Stent optimization patient showed a significant low rate of the MACE. So this is the study-level meta-analysis comparing the OCT and NGO for the target vessel failures. So as you can see, definitely OCT-guided PCI found to be associated with a great reduction in target vessel failure in complex reason as compared to the NGO-guided group. This is our Occupy subgroup analysis. So is consistently OCT's favorability is maintained, especially the chronic total occlusion, the yes or not, without group interaction showed a consistent finding by OCT guidance. So ladies and gentlemen, this is my take-home message. For the successful wiring, IVUS guidance is very useful in case of the Stumpless CTO and sometimes of wires on first lumen. In this kind of case, tip detection method or tip detection ADR would be helpful. So by using the pre-procedure CT scan, high success rate with low immediate complication could be expected then compared to the NGO guidance. For the successful clinical outcome after CTO success, IVUS guided CTO intervention is by improving the stent expansion lead to the better clinical outcome, and also the OCT guided complex PCI similar result with IVUS in the future findings eagerly anticipated. Stent optimization using imaging guidance is the key factor. So as everybody know, this is the ESC guideline of this year for the chronic coronary syndromes. IVUS intracoronary imaging by IVUS or OCT is now 1A. In particularly left main system, true bifurcation, and long lesion. So I just want to, the CTO is already included in this kind of a complex region, or a CTO will be added in the next time guideline. Thank you for your attention.
Thank you, Dr. Kim. That was a wonderful summary. Can we ask, or maybe you can come back, that's fine. May I ask you, you have covered almost everything on imaging in CTO, but what are your thoughts on subintimal tracking and DCB, or so-called investment procedure in CTO?
Okay. You mean the comparison of DCB and STEM?
For example, if you found from the imaging that you have a long subintimal course of your CTO, will that change your stenting strategy? You will just rewire or stent subintimally? That's my first question. Second one is regarding the investment or DCB use in the CTO.
Okay, so as for the long-term outcome of the first lumen tracking using the DES, already JCTO Club had a kind of some data is definitely long first lumen tracking is related with the high rate of the TVR or future worse clinical outcome. However, it sometimes already Dr. Hamazaki cases also told us some CTO operators already exhausted, and also sometimes with full-time intervention already passed. If that, even we know the long first lumen not so good. However, sometimes just stenting and also full medication sometimes would be good. However, if possible, it's definitely the imaging guidance again of the reducing the length of the first lumen. And also, DCB is a kind of different field, especially in the CTO. So the first one is mechanically more complex region, usually the in situ. So even with some kind of very easy way to use a DCB, however, sometimes very worse clinical outcome. So we need more data regarding some DCB or DES in situ field. But now is anyway the standard treatment. I think DES would be for the successful situ intervention.
Okay, so I think for the time we have to close the session. Thank you very much for a wonderful session. Thank you.